Okay, and with that, Edward and Peter, I'm going to turn the mic over to you.
Thank you, Kimberly, and welcome everyone. Today's presentation is provided by the Preparedness section at the Kansas Department of Health and Environment. I'm Edward Bell, Preparedness Program Deputy Director, and with me is Peter Rafferty, Preparedness Section Healthcare Coalition Program Manager. Today, we're going to provide an overview of the healthcare coalitions that are in Kansas, and healthcare coalitions are also known as HCC, or HCCs in this case, that are in Kansas and how they work with both public health and the communities across the state. As you can see by our agenda, today's topic is going to cover the development of, the expansion of, and the future of the HCCs in Kansas. So we're going to touch on some historical background, coalition development, some hurdles that the HCCs have had to overcome and are still working on, links to public health, the HCCs and their role in the recent COVID-19 pandemic, current HCC projects, and what the HCCs are going to be looking to do here in the future, what the future holds for them. Next slide, please. So there were many events going all the way back to roughly 1993 that spurred the development of the healthcare coalitions as well as the current FEP program on a lot of the preparedness oriented things or programs that we deal with today. This is not a full list by any means. They're just kind of the highlights. Kind of starts in 1993 with the first bombing of the World Trade Center. And of course, 9/11 was what really got things going. The follow-up anthrax attacks, which were considered a follow-on from 9/11. The 2 years from 2002 to 2004 with the SARS-CoV-1 or CoV-1, which was a limited wave of COVID. We saw the development of the Middle Eastern Respiratory Syndrome, otherwise known as MERS, which was a SARS-like outbreak in the Middle East. In 2014 through 16, as we all recall, there was the African Ebola outbreak. And it's been one of many that have occurred since the virus's discovery. And then, of course, from 2019 to present with the SARS-CoV-2 or COVID-19, which was pretty much felt around the planet. Like I said, this is a very short list. There were many other events and situations that came up that drove the need for an all hazards planning in order to enhance and expand emergency preparedness at all levels. Next slide.
The event of 9/11 polarized the country and sounded the alarm that the U.S. faced threats from abroad. Add in outbreaks from Ebola in Africa, the MERS outbreak in the Middle East, and the distant cousin of COVID-19, SARS-CoV-1 outbreaks, and numerous natural disasters led to the need of an all-hazards approach to the preparedness and response. Hence, the National Response Framework and the National Incident Management System came into being. These two publications are the backbone of the federal response. These documents also created a concept of an unified or integrated command structure that permitted a focused and unified response during an event. Next slide, please.
In the early years of the HCCs, the coalitions were driven by what was referred to as the regional hospital model. Regional hospitals were identified were identified by one in each coalition area and served as the fiscal agent for the HCCs in Kansas. In some other states, the HCCs were recognized response entities and therefore could be their own fiscal agent. The regional hospitals determined who the coordinator was and they handled their contract. They also handled, in turn, funding for each one of the hospitals' work plan activities. As some of us recall, back then, we had roughly 142 to 145 different hospitals, and they were all separately contracted. Each hospital, additionally, KDHE also maintained a contract with the Kansas Hospital Education and Research Foundation, or KHERF, to manage programmatic tracking of the hospital's process toward work plan completion. And then they in turn would report to us. And then we in turn would report to ASPR. ASPR is the Administration for Strategic Preparedness and Response. During this time, only the hospitals in the state could be a coalition member. Both the hospitals and their regional coordinators had work plans to complete. This created an environment where the hospitals received the bulk of the focus. During this phase, the funding was provided with the state acting as a pass-through, which it still does, and the grant application encompassed both the Hospital Preparedness Program, or HPP, and the Public Health Emergency Preparedness Program, or FEP. Both of these came together and were known as a cooperative agreement. When the state, otherwise known as the recipient, applied for the HPP side, they also had to apply for the FEP side as well. Next slide. The regions in the state were determined through various means and have remained unchanged through to the current project period. The HCC footprints tend to match several other agency or department footprints like KDM, KDOT, or DCF. These allowed for a balanced approach to providing coverage across the state and remain aligned with the other agencies. It was determined that at that time by KDHE that following the already established regions along with patient catchment areas for each of the major hospitals, this was the best way to identify those boundaries. The state's two largest regions by population are the South Central Kansas Healthcare Coalition, centered around Sedgwick County and Wichita, and the Kansas City Metro Healthcare Coalition, made up of only the facilities within the counties of Wyandotte, Johnson, and Leavenworth. The other coalitions, known then as Northeast Kansas HCC, North Central Kansas HCC, Northwest Kansas HCC, the Southwest Hospital Emergency Response Team, or SHIRT, and the Southeast Kansas HCC. Each HCC had a healthcare coalition coordinator that was contracted through the regional hospital with KDHE's approval. Next slide. Sorry about that. Peter seems to be having some technical difficulties.
I'm sorry, my internet kind of got a little wonky there. Allow me to start over. Changes came in 2017 with the transition to a healthcare coalition-centric model. This meant the hospitals could no longer receive the funding directly from the Administration for Strategic Preparedness and Response, or ASPR. Funding was provided directly to the HCC or through the fiscal agent representing the HCC. In Kansas, the newly renamed Readiness and Response Coordinators, or RRCs, would step in to fill this role. Additionally, this full-time coordinator position would be joined by a clinical advisor and the identification of a lead hospital. In some instances, the HCC adopted the former regional hospital in that role, or more than one hospital shared the role. This revamp of the HPP saw the adoption of 4 capabilities: Capability 1, Foundation for Healthcare and Medical Readiness. Capability 2, Healthcare and Medical Response Coordination. Capability 3, Continuity and Healthcare Service Delivery. Capability 4, Medical Surge. Each of these capabilities are broken down into a series of primary objectives and supporting activities that would guide the HCCs in the completion of their work plans. HPP adopt the HPP Readiness and Operations Cycle, then introduced a budget period long workflow that started with planning and preparation, flowing by training equipment procurement, which led to exercising and response, and finished up with evaluations and sharing of lessons learned. Next slide, please. The coalition concept was defined as having 4 core members, and then other members as defined by CMS and ASPR. These include private providers, infrastructure organizations, first responders, and law enforcement/public safety. These additional provider types were determined by ASPR and aligned somewhat with 17 provider types recognized by Medicaid and Medicare CMS. The core member requirement is hospitals and ACH or a CAH, local health departments, EMS, and emergency management. This model pulled the focus away from just the hospital and spread it out across the entire preparedness and response arena. Conceived as response entities, the HCCs would be tasked with various requirements for the new grant. This included, but not limited to, hazardous vulnerability assessments, or HVAs. This assessment is completed annually and drives the identification of training and plan changes. Plan creation. The HCC would have to develop a preparedness plan and a response plan. These plans would initially develop as drafts, reviewed and adjusted by the HCC members, and then ratified per the governance. These plans would be reviewed annually and changed as needed. Governance. As an organization, they would serve as coalition bylaws. These would also, under annual renewal review by the members of the HCCs and re-ratified each budget period. Surge plans. The HCCs would need to create annexes to the response plan that cover various surge events. The surge plans are created as drafted, tested on a tabletop exercise, and then adjusted based on the after-action review and improvement needs identified by the group. Cash management. The HCC would be responsible for managing their cash inventories. These and others would work to define the HCCs from budget period to budget period. The caches have undergone several transformations over the last years in an effort to become more viable and expansive to allow for supplemental supplies in time of need. Next slide, please. Oh, back one, please. Okay, you were right, I'm sorry. There are presently 7 HCCs, and each has their own readiness response coordinator. The RCCs serve as the backbone of the coalition. They are a required position by the ASPR, garnering 1 FTE per coalition. Currently, the Healthcare Coalition Partners of Kansas, LLC, is contracted to provide RRCs for the HCCs. The HCC partners manage the RRC's time, serves as first level reviewer of all HCC deliverables provided to the KDHE, and acts as a liaison between the HCC program manager, program, and bureau leadership. Those coalitions are Kansas City Metro HCC, Northeast Kansas HCC, North Central Kansas HCC, Northwest Kansas HCC, Southwest Kansas HCC, South Central HCC, and Southeast HCC. As mentioned, the HCCs must maintain a full-time position with a readiness and response coordinator. Due to the HCCs not being legal entities, the RCCs also serve as the fiscal agents for each of the HCCs. This allows them to conduct HCC business. Currently, the RCCs are contracted through the KDHE. The contractor is the Healthcare Coalitions of Kansas, LLC, led by co-owners Danielle Martin and Tammy Wood. Next slide, please. The HCC or Coalition Readiness Response Coordinators are as follows. Andrew Conyers as the Kansas City Metro, Danielle Martin as the Northeast, Tammy Wood as North Central, Jonathan Blackbird as the Northwest, Mindy Bremer as the Southwest, Jamie McHugh as the South Central, and Fred Ryan as the Southeast. Next slide, please.
The response roles for the HCCs in Kansas are rather limited. These limitations are primarily due to the HCCs not being recognized as legal response entities or legal entities in general. This leads to the state's Emergency Management Division, KDEM, being to be the legally identified response entity in the state in most instances. This is fully defined in the federal Robert T. Stafford Disaster Relief Act as amended, and in Chapter 48, Article 9 of the Kansas statutes annotated as listed in the Kansas Response Plan. Because of this, the HCC's response roles in the event of an incident is that of a support role, primarily being information sharing and communications. This allows the HCCs to bring their expansive network of contacts forward to assist with the logistical lift that is most always present during an event. Their other role, communications, works hand in hand with the information sharing role. To date, the HCCs can pass on helpful information through various social media and privately owned and operated communications platforms. These platforms range from Facebook, specialized alerts, emails, and text. One specialized platform, the HCC-owned INA Alert Network, allows for additional communication capability that came in very handy during the COVID response, and their information sources were provided to the State Emergency Operations Center, or SEOC, as additional source of information from the field. Another area of expansion was in logistical support. The coalition caches, and later a much larger COVID personal and protective equipment, or PPE, specific cache, was helped to supply facilities within their footprints with additional supplies. At times, this was expanded further to include delivery of critical equipment to hospitals around the state. This is one of the reasons why the HCCs were recognized by the governor in 2022 with a proclamation declaring that the last week of September, which is Preparedness Month, to be the Healthcare Coalition Appreciation Week. Next slide, please. Prior to 2017, the local health departments and/or public health emergency preparedness coordinators were only required to attend a single HCC meeting during the budget period. The HCC work plan never mentioned the involvement of local public health or the FEP regions within the HCC. For the longest time, public health, working in the background, completed their separate work plans that did not always entirely align with the HPP work plan and the hospital-centric model. As a result, local public health departments and their regions would have differing capabilities that would not always align with their HPP counterparts. The result was either a misdirection of work between the two sides of the program, or it left local public health guessing on how to align their activities. During the brief budget period that spanned 2016 to 2018, and later in our current project period, ASPR and CDC shifted how the HCCs would interact with local public health, as well as local communities on a whole. Both agencies determined that better outcomes could be made through collaboration rather than just attendance. The grant also changed as the cooperative agreement became two separate but linked agreements. Capabilities on both sides changed, steering both towards a better aligned together, but still somewhat separate. This trend continued into the current project period. Along with being a CDC grant requirement to participate in HCC activities, public health is now one of the 4 core members, their participation being a requirement for the HCC to actually be officially recognized as an HCC by ASPR. Additionally, HCC memberships were expanded out to include nearly the entire gambit of public services, public safety, infrastructure organizations, companies, and agencies. Both HPP and FEP now approach preparedness from a community standpoint, not just strengthening the hospitals and helping them prepare, but including all aspects of the community at the local, county, and regional levels in order to help them better prepare by being a resource toward that end. Public health remains linked to the HCCs much in the ways it did, but not under the hospital-centric model. Next slide, please. In recent years, the role of the HCC in public health, as well as community preparedness, has been to provide another set of resources and partners in an overall role of preparedness. The HCCs also provide a joining link between the realms of public health and the clinical healthcare, while looking to the greater community as part of that picture. Along with that role, the regional FEP coordinator and FEP regions, the HCCs and its members can provide meaningful outlets to expand preparedness activities across the communities. And these are some of the ideas. These are some of the things that the HCCs do in order to expand their preparedness activities. These include ready assistance with the creation of needed plans. The HCCs have a lot of experience with plan development. They're another source of support in time of need. They can work closely with FEP coordinators. They're an additional level of communications. They're viewed as a partner rather than a bench warmer. They have a voice across a larger platform than the FEP regions by themselves. They've improved regional support. Through the lessons learned, the current partnerships can grow even stronger. And in Kansas, public health can submit proposals for HCC mini grants. Next slide. The current HCCs have made changes that allow their benefits to be extended. With the extended membership, the HCCs have the better ability to serve their communities that they're in. This can range from assisting local business with the development of strategic preparedness plans, provide useful and additional information to local and county leadership, provide additional information to emergency managers, and provide training to the community partners, as only a few. And some of these listing here is, I think a lot of us have had or have heard of the training, the Stop the Bleed program, Train the Trainers. That is a very popular one with the HCCs as well as with the public. Next slide. As we all know, COVID-19 came to redefine the Kansas HCC response role. While the HCCs remain limited in their response capability during the early weeks of the COVID pandemic response, they worked closely with other state partners and proved to be helpful by providing another organized community that could assist with the distribution of information to the public, a secondary source of information that was available to emergency management, was to due in part to the readiness and response coordinators having better networking capability, along with the HCC members and other partners in the state. This led to a clearer picture being presented to the state and its response partners. Additionally, it opened up another supply of pathway via the HCC cache system, and later that larger centralized COVID-19 PPE cache that was conveniently located in Wichita. RRCs and HCC members were able to move various pieces of equipment that were either obtained by the HCCs or through other outside various means. Through these efforts, the HCCs were able to influence the response outcome alongside their emergency management and public health partners. Next slide. Currently, there are a few projects in the works, but these are the most probably pressing ones that the coalitions will be involved in, or either directly or indirectly. Their projects involve internal and external partners and may have deeper regional impacts for Kansas once they're fully implemented. The first one is the development and integration of long-term care facilities and EM resource. The HCC Communications Work Group, which has been a long-standing group now for about 6 years, has been involved in developing processes to bring training to long-term care units, or LTCUs, that covers the use of EM resource. It is hoped that once the LTCUs are trained in its use, they'll have a better picture of bed availability in the state. It's also hoped that by having this increased level of awareness, the LTCUs in the state will have a better idea where to send patients that need care, as well as allow hospitals to see what is available in the long-term care or post-acute care setting.
EM resource / hospital EHR data sharing project. During the pandemic, there was an enormous burden on hospitals to report up to their federal partners like the CMS or CDC their ongoing bed numbers. This required one or more persons to upload extensive amounts of data 2 or more times a day to several federal databases. This project will start with 3 hospitals pilot program that will generate lessons learned, best practices, and the best process to present it to the rest of the hospitals in Kansas. Next slide, please. 2024 represents the last 2 quarters of the current project period. Ashford is working to develop the next capabilities and activities for the next project period, using lessons learned from the COVID pandemic and many others that have occurred over the last 5 years. Next slide, please.
We've been given some tentative idea what these capabilities are going to look like. However, they are still basically on the, they're still in extreme draft mode. So we're unable to have, we don't really have any information regarding the new capabilities and how they'll impact both the HPP and the FEP programs. We've been told that a lot of lessons learned from COVID, there will be quite a bit of equity related features built into the next set of capabilities. And we will be adjusting what we do now to meet those needs. And that will pretty much end our presentation. I will now open the floor for questions. If you have any questions, again, please place them in whichever one of these is working, which I believe is the Q&A. So we'll go with the Q&A.
Actually, both chat and Q&A are working now for everybody. So, oh, there you go. There's a question.
Ah, cool. They're both working. We got a question? I'm not seeing that question.
Julie asks, what are the HCCs doing for future pandemic planning with regards to PPE?
That's a very good question. Right now, as we all know or may not know, I keep sometimes forgetting that we have not as many medical personnel in this call than as with other ones I've done on this. As with anything that is sterile or goes on the human body or provides some kind of protective factor for the human body, whether it's for a disease or chemical or whatever, there's always an expiration date to always take into consideration. We have had the HCCs look at potential alternate vendors that they could pursue in the event that we have, like with COVID, where we had a PPE shortage, so that they're able to spread their order requests for supplies across a larger number of vendors rather than trying to hit just one. Additionally, the COVID PPE cache was actually dismantled and spread out amongst the 7 HCCs. So from a supply standpoint, the coalitions all have what's referred to as an inventory management protocol plan, otherwise known as IMPS. I actually coined that phrase. I had somebody from Asper actually use it and I kind of giggled. But the plan sets up a rotation and an ordering routine so that as supplies begin to near their expiration date, they can be rotated out and replaced with new supplies. The rotated out supplies, we encourage our HCCs to look at the universities that do like the veterinarian or vet programs, the medical programs, PA programs, anything where they could use either near expired or expired PPE so that it does in fact go to good use and just isn't thrown away.
Thank you, and I'll read the next question.
Sure.
It's from Edie. Actually, it's 2 parts. First part is, I know you touched on it briefly, but how can HCCs help emergency managers across the state? And then how do emergency managers benefit from a regional HCC?
Well, question 1, and we discovered this during COVID, was the readiness and response coordinators, along with several of the various members within each HCC, have a very wide, very far-reaching network. When it came time to start moving patients around, and as we all may or may not know, there was a very hard time indeed times trying to find open beds, trying to find open appropriate beds at various facilities. It was sometimes the RRC, the readiness response coordinator with the HCC, along with their members, who had a better feel about what they had open in their own bed, in their own facilities. With the requirement that hospitals do this either daily or 2 times a day, reporting to 3 and 4 federal databases, which took a lot of time because there were probably between 64 and I want to say 180 different data points that had to be uploaded. And these range from various metrics, like how many general beds you have, how many of this type of bed you have, how many patients have you seen with this, how many patients have you seen with that, how many discharges, and the list goes on. EM Resource, which is a very viable method of transferring a lot of that information within the state, kind of fell by the wayside. So we're trying to look at improving that system, and emergency managers also have access to that system. So, sorry, what was the second part of that?
Okay, part 2 was, and then how do emergency managers benefit from being a member of the regional HCC?
Emergency managers would benefit because they would have access to all that information. They would get an idea on what's going on with their health department or their hospitals or any of the other members. Members can range anywhere from clinic members from just community clinics. We have dialysis centers. We have urgent cares. We have standalone surgical units, standalone emergency departments. These are ERs that are away from the main hospital. You have local police, fire, sheriff, KHP. There's a plethora. They become a plethora or a source of information for that emergency manager to use. And all that information can either come straight to the emergency manager or can be siphoned through the readiness and response coordinator, who also basically acts as a liaison to the public. And I hope that answered that right.
Okay, please, if you do have questions for Peter or Edward, please type them in the chat box, and thank you to the 3 questions that we just had.
Yeah, those were very good questions.
Don't see any additional questions yet. I'm going to go ahead and put your contact information up in case
Right
you're
ahead.
looking to possibly type a question in there.
Oh, there they are.
Did you find it?
Yeah, they were at the bottom. They just now appeared. Apparently having a Q&A delay.
Maybe wait another minute here and see if anybody has a
Sure thing.
question. I wonder if everybody on today's call, were you familiar with what an HCC is? I know I learned a lot. Thanks for
I know
that.
there are a few in there. I've seen a lot of county health department directors. I see a few actual HCC members. I won't say who you are, but I know you're there.
There's a question. Do you want to
Question.
grab that?
See it. Let's see if it comes up for me.
Okay, tell me if it doesn't.
Go ahead and read it.
Okay, this one is from Julie as well. And she asks, if medical facilities such as surgery centers want to conduct a disaster drill, does the HCC need to know?
HCC, however, if that facility would like the HCC's assistance in planning that drill, we encourage them to reach out and talk with them. But the coalition does not, there's no reporting requirement to the coalition. I'm assuming this is a CMS related requirement or another accreditation requirement. I will add that the HCCs also conduct several exercises, or at least 2 exercises during the year. One of those is the aforementioned surge exercise, which tests that surge annex. It is a tabletop exercise. The other one is the medical response or medical emergency response and surge. We call it MERCY. For those of you that have been affiliated with the HCCs in the past, the MERCY replaces the surge test. Is a much more expansive exercise. And ASPR, when they redeveloped it, had determined that facilities that have like Joint Commission or CMS exercise requirements or any other accreditation requirement that they also need to drill on, that those particular objectives can be added and worked into that MERCY so that we basically take care of multiple things at once. There are tabletops on how to conduct drills. If you go to our kansaspreparedness.org and look under preparedness, you will find a large library of various drills and exercises. You'll need to contact Luke, and I'm going to put his address or his email in the chat. And he is our training and exercise coordinator. And he will be more than happy to help you find a drill. Actually, will help you teach how to conduct a drill, as well as provide a workshop potentially for you.
And I just shared that email address to everyone.
Oh, cool. Thank you.
Just in case anybody else, like that information too.
Mm-hmm.
Does anybody else have any questions out there? I know there's still a good group on here. I might mention while we're just waiting to see if a question will pop up, is that yes, that was just what I was going to announce, Edie. So yes, we are recording this, so we'll share the recording as well as the PowerPoint, if that's okay with you, Edward and Peter, with everyone who registered for the webinar today. Also, I think we'll probably put it in our library for access for those if we get questions, on what is a healthcare coalition, because we know there's a whole lot of staff out there across the state that probably are unaware of what an HCC is. But I'm sure within each county, they have staff that are aware of it. So, but yes, we will definitely get that shared out to everybody.
And I have the email, or not the email, but the website address and I have that going to everyone.
Oh, perfect. I'm sorry, I read your question wrong.
Oh, no problem. And if you have not been to the KDHE website, while it has been, so it's kind of got a new look. Any other questions, comments?
Yeah, I'm not seeing any, Edward. Okay. Well, I want to thank both Edward and Peter for joining us this afternoon to prepare this. Looks like a lot of information, a very detailed presentation. But then I've learned through COVID that anything dealing with the health field is very detailed and thorough. So again, we will share out the PowerPoint and the recording link to everybody registered for the webinar today. And as always, if you have any questions, you got the contact information up there for Edward and Peter, and I'm sure they'll be willing to take some. And as well, remember, you can refer your organization or your county staff to the presentation and the recording link. That's what we always have up here from KAC. You know, doing these types of presentations are important, and it's the sharing on that's really beneficial across the county. So please be sure, you know, just share that to those who would be interested within your county. And Edward or Peter, do you have any closing thoughts you'd like to add?
I would like to thank everybody for their time and to allow us to provide this presentation to you. And if you need to know anything else, once again, our email addresses and contact numbers are on the screen and will be part of the slideshow presentation that will be shared out.
Great. Well, with that, thank you again, Peter, and thanks for everybody as well joined the webinar, and we wish you a great, safe afternoon. Take care, everyone.
Take care.